I'm actually working as the palate cleanser after all the surgical videos before lunch. It's hard to follow a couple of talented surgeons, but my pictures are a little less invasive, so. And I will start by saying I have 3 children, so thank you for the opportunity to come here today. Minneapolis in March always sounds better than my 3 kids in the South. So the other thing is I also am a dry eye patient. I have dry eye disease. And I learned that I better be nice to those 3 kids in case I need a conjunctival donor one day. It's not looking good. It's not looking good. So we're going to talk about a couple of dry eye masquerades that you may encounter regularly in practice. We've talked a little bit today about the importance of diagnostics and making sure that we're properly diagnosing our patients so we can properly treat them and not discourage them in their journey. So what are our masquerade conditions? These are some of the most common: allergy, blepharitis, of course, medications that our patients are taking. How many of us have our technicians and staff intake our patients for us, do the history and so forth? Show of hands. A lot of dinosaur arms in the room, a lot of these. Yes, we all do. So when they put this into their record, okay, how many of us go back and look at the medications? You know, it's in there, but not a lot of doctors do. A lot of doctors go back and look at medications when they're going to be writing a prescription, when they're concerned about an allergy, perhaps when there's something that they think is impacting the ocular surface. But a lot of times it's just in the record, but not really ever looked at thoroughly. Ocular disease, of course, is part of that, but systemic disease is another consideration. Our case in point today was our autoimmune patient. Certainly autoimmune groups, but that only makes up a fairly small patient population for us. It's kind of growing as we see more disease coming into the population, but we also have to be mindful of dermatological things like rosacea and other systemic conditions that may be a part of that. And then lid positioning, as Dr. Donenfeld said, floppy eyelid syndrome, we see this all the time, but it's not often diagnosed. We have an unusual designation in eye care as eye care providers that we've touched an inordinate number of eyelids, more than the general population, right? And you know what that laxity feels like. And you do a little snap test, you pull down and you see it spring back up. That's pretty good apposition to the globe. But if you see that slow pull back, then that's going to be somebody who's got floppy eyelid syndrome. And then there's that concomitancy maybe with sleep apnea. So there's a greater health concern that we need to perhaps be addressing with our patients. So we're going to go through a couple of cases. Probably hear this regularly. My eyes run. Okay, or maybe that's a Southern thing. Okay, I should have also given the disclaimer, if you don't speak Southern fluently, hopefully someone sitting next to you can help translate. You might need a little bit of that because I do say dry eye. All right, so what's our case history look like? These are common patients that you're going to see, 53-year-old Caucasian female, and it's not to say these patients may not also have dry eye components. So if you look at some of the diagnostic testing or some of the other components of the slit lamp, you may say, well, I see some dry eye in there. That's true, but what may be part of the underlying condition that we may need also to treat. So she has excessive tearing, and she has moderate to severe at times. It's happening in both eyes, and it tends to be intermittent. So what is she taking? We talked a little bit about medications. We talked about allergy medications earlier. She's also got some hormone replacement therapy as well as an antidepressant. These conditions have been going on for the last 3 to 4 years. She also wears a multifocal contact lens, and she's unhappy with that fluctuating vision. So if you're fitting your contact lenses, particularly multifocal lenses, looking at dry eye is really important. A lot of our contact lens wearers are going to experience dry eye disease about 10 years before non-contact lens wearers. So we need to be mindful of that. And a lot of that problem with these folks is they wind up dropping out of their contacts, and they want to stay in them a lot of times. So mild seasonal allergy with her history, and we see her generalized anxiety disorder and some mitral valve prolapse. So in total about medications, we've talked about this a little bit before, but some of the big ones are right here. What it doesn't say is that about 1 in 4 women over the age of 50 in the United States takes an antidepressant. So we need to be mindful of that. Now, does that mean tell all your patients to stop their antidepressants? No, certainly not. That's bad for everyone, right? No, but what we do need to do is tell them this is something that we're going to have to kind of work around. So again, in our patient, Claritin and her Primpro and Lexapro. Her visual acuity is good. IOP is essentially normal. Osmolarities we talked about before, our cutoff point for osmolarity is 308. So she has a fairly normal osmolarity. Her inflammatory, however, is positive. Lipid layer thickness is still high. If you're not familiar with lipid layer thickness, as we measured through LipiView 2, we're looking at it to be around 100 is perfect, but 90 to 100 is ideal. So she's right in that ideal area. You know, a lot of times I try to make diagnostic information relatable to my patients. And once I said to one of my patients, so your lipid layer thickness is about a 40-something here. And I said, you know, let's kind of compare this to a spelling test. What would you love to have gotten on a spelling test when you were younger? She goes, oh, I don't know, 70? I said, really? Dare to dream. You know, this is what you pick. You pick 70. And I said, no, we're shooting 90, 100. That's where you want your lipid layer thickness to be. So we also have phenol red thread. If you're unfamiliar with that, anything say 15 and greater is going to be essentially normal. I do that as preference to Schirmer's testing. You can look at tear prism height and get a lot of that same information. Consider my practice background as an academic setting, so I'm showing a lot of my students a lot of the instrumentation, a lot of the tools. Does that mean I have to do a full court press on every single patient? I certainly don't, but it's an educational opportunity. OSDI, or Ocular Surface Disease Index, is a 47, frame of reference 0 to 100, 100 being the worst you could possibly feel. So she's pretty symptomatic. So she does have a little bit of rare Demodex at her lid margin, a modest edema at the puncta, which I highlighted for you in case you're drifting off before lunch and you're like, just show me the highlights. She also has a 2+ papillary reaction, no conjunctival chalasis or CCH, clear cornea, trace NS, and her tear breakup time is a remarkable 7 and 8. So those are all pretty good things. So what's the problem? What's the patient have as her real underlying condition? It's really more about the allergic conjunctivitis that she has. So I'll show you some images, a little bit of trace Demodex, and then as we go into the conjunctiva, you can see the papillae that's present there. So a little word association for the eye care providers in the room, okay? Play along. It's really, really sad when you don't play along, okay? It's just me up here staring at you. So if I say itch, what do you say? Allergy. Okay? A lot of times you're going to be right, and thank you for playing. A lot of times you're going to be right, but the other thing that itch can be is Demodex. So we want to be mindful for that. A lot of doctors will hear itch, say, here's your antihistamine, move on to the next patient. Make sure you look at the lid margin for blepharitis and Demodex as another complaint that they may have. So we look at the masquerade complaints. We have the itch, which could be that Demodex or anterior blepharitis. She does have that epiphora, some mild foreign body sensation. She could have some irritation. So, you know, the complaint with allergy is really concomitant with dry eye a lot of the time. So again, allergic conjunctivitis, dry eye, all those things tend to kind of cycle between each other. They can. So be mindful of allergic conjunctivitis. It's one of your primary masquerades. It could be environmental. It could be something as an indoor allergen, but we see it all the time. The side note to this particular patient, she slept with 3 dogs, okay? And I had her go do allergy testing, which in the state of Tennessee, we can actually do our own skin testing in office, and we do that sometimes. But I had sent her out to her allergist because she had a pre-existing relationship with them years ago. She found out she was allergic to her dogs. So at least now she knew to get treated. The dogs are still in her home, but moved from her bed. So the punctal swelling was probably what was the origin of the epiphora she was experiencing, because it was really, really tight. And once she got allergy treatment, she did see a difference and a decrease in the epiphora. All right, so next complaint, my vision is gone. Now, as a dry eye doctor, this is not my favorite complaint. Okay, I don't do the retina, so I'm not looking for an RD to come in my office. So my vision is gone is not my favorite complaint at all on a Friday at 5 o'clock, right? Okay, so let's take a look at this case. 93-year-old Caucasian female. She is the smartest cookie you've ever met. She comes in, she's an avid reader, or she once was. We're going to find out in a minute. Her vision's prohibitive for her being a reader. She did find audible.com and, you know, loves that a lot. She's got no pain. We talked about the anesthesia of the cornea after you've had dry eye disease for such a long time. However, her complaints are severe. It's in both eyes, and she's using an artificial tear, but she's had a history of using a lot of different things like cyclosporin for the last 3 years, but many other treatments as well. So currently using a topical overnight ointment, artificial tears. She does have a care provider, so we know she's adherent to the medications that we're recommending or have been recommended. This is how she came and referred to me. She's also using cyclosporin twice a day. And she's had cataract surgery and history of migraine. Let's look at her visual acuity. This is not a happiness kind of thing for a dry eye patient. We're looking at 2600, 2400 vision. Her IOP essentially normal. Osmolarity is incredibly high at 323 and 333. You know, as you look at osmolarity, we know our breakpoint to be 308. However, as the disease process continues, you can see a greater asymmetry between the two eyes, which can be a hallmark of that progression. Lipid layer thickness is low, phenol red thread is essentially normal, and complaint level, though she doesn't have a high level of pain complaint, she does have a high level of complaint with the disease process in general. By looking at the anterior segment, she does have moderate telangiectasias of the lid margin, rare blepharitis, so overall good lid hygiene, increased lid laxity, didn't appear to be a floppy eyelid syndrome type case. However, at 93, I'm pretty much thinking everything's lax at that point. I don't know. And then we have conjunctival hyperemia, and then severe diffuse SPK. And SPK really doesn't describe it, and you'll see here in just a moment what the pictures look like. Anterior chamber deep and quiet, but a bit of a poor view considering the ocular surface. She does have her IOLs, her tear breakup time is instant. So this is what her cornea looks like, and to really appreciate the image here, you have to look at the reflex. You can see how irregular it is. Basically, she looks like she's had PRK or epiLASIK. More or less, her epithelium is entirely gone in both eyes. However, her level of complaint, remember, with pain is incredibly low. So the prediction is, at least over the years in her history and by getting her records, is that she's had some severe EBMD that at 93, she's just unable to keep the top layer of the cornea on. So it's severe, it's chronic, she's got some glare and photophobia, but some of these patients, again, may be asymptomatic, particularly in the early stages. Things to keep in mind, EBMD affects 42% of individuals of all ages. So if you're not seeing it, perhaps you're not looking. You know, it depends on how you look through your slit lamp. I use a diffuser a lot because I do a lot of anterior segment photography. If I use my diffuser, I can't see the EBMD. If I flip it down, I can. So just kind of be mindful of your technique behind the microscope as well. So as you can see, when we put lissamine green in, it really highlights the perimeter of the epithelial defect. And you can also see the telangiectasias at the lid margin. So a lot of misery and unhappiness. What I wound up doing was inserting a cryopreserved membrane in the eye and had her come back about 3 or 4 days later for removal of the lens. And for me, I don't know, how many of you use membranes in the audience? So a lot of you using cryopreserved membranes? Okay. So I don't know about you, but my incidence of tiny fissured patients with cryopreserved is always very high. So this woman's 93, has the fissures of like a newborn. And, but needless to say, I got it in. It was no problem. So, and getting it out is no problem either. All right, so we put the lens in, and this is what she looks like as she comes back. So we still see a good amount of inferior staining, but look at the reflex in the eye now. It's totally smoothed over, a remarkable change. You know, you get to be your patient's kind of hero when you make this enormous change in such a short period of time. And you know, the stem cells that are within these cryopreserved membranes are really advantageous and can give that real wow factor to the patient. Now, what I did find with her in subsequent follow-ups is that she couldn't maintain the integrity of the cornea after using the cryopreserved membrane. So I could get her happy, I just couldn't keep her happy. Sounds like spouses, right? get them happy, you can't keep them happy. So with this one, actually, what I decided to do was to use a product, which is an amniotic tear, as a follow-up, because the cryopreserved membrane could get the majority. I needed a big bang for the buck, but then I needed to be able to maintain that success, and having that constant application of those stem cells via the amniotic tear was beneficial. Now, as we've sort of determined today, the answer seems to always be what? Scleral lens, right? Courtesy of Dr. Burnett, the answer is always scleral lens. I'm kidding. But in this case, because of her care that was required through home health and so forth, that wasn't really going to be a good, safe option. However, if she were in a younger subset, I would consider using something like a scleral lens to maintain that success, perhaps putting the amniotic tear in the bowl of the lens and then putting the lens on top, which I've done on other cases. So the next case is I have dry eye. So I work primarily in a tertiary dry eye center, so most of my patients come in self-identifying as dry eye patients. They already know they have, and I don't know if you do this wherever you live, but do they have the something? Do you know what I mean? They have the cataracts, the glaucoma, the diabetes. Well, she had the dry eye. So this patient comes in with the dry eye. She's a 71-year-old Caucasian female, and she's reporting, again, runny eyes. Epiphora is always the hardest thing to explain to your patient, isn't it? Why watery is actually dry. I mean, we could all spend probably 15, 20 minutes each day talking about just that one thing. So the patient says runny eyes. This has been severe. It's been daily, near constant. She uses artificial tears with absolutely no relief. She's had punctal plugs that fell out. Extrusion rate of punctal plugs can be as high as 60%, so that's not an uncommon thing that we hear. The secondary complaint is a little bit of mild itch. She's taken those ocular antihistamines, as we've talked about. You can see here osteopenia, osteoarthritis, morphine, ibuprofen as allergies, and she's taken cyclosporin. Acuity is pretty good. IOP is good. A little bit of hyperosmolarity in the tear film. Inflammatory is negative. Lipid layer thickness is a little bit lower than we would prefer, but not terrible either. And then our phenol red thread, she's saturating it at 30 plus. So this goes along with the complaint of epiphora. So her prior and failed treatments, again, artificial tears, punctal plugs, and cyclosporin. So what are our objectives of these? This is really to raise the tear film, and it's also to decrease inflammation and to lubricate. So what are some of our common causes of epiphora? Why might we experience this, or our patients experience this? External agents, corneal abrasions, things that we would triage pretty regularly, but can also have an infectious origin or some sort of obstruction that may be the origin of the complaint. So for anterior segment, clear, no debris, so lid hygiene is good, deep and quiet. She's got her PCO IOLs that are centered with just a little bit of PCO. But the key finding here is that she has redundant conjunctiva. So this patient has conjunctival chalasis. And conjunctival chalasis is one of the things, not unlike floppy eyelid syndrome, that is very uncommonly or misdiagnosed. It's really overlooked in our slit lamp exam. And even if it is, it's not acknowledged or graded. It's just a positive or a negative. It's almost a binary thing. They have it, they don't have it. So with our patient, you can see here a lot of redundancy of the conjunctiva. Perhaps what the photography doesn't really identify is it's honestly just sitting on the lid margin. It doesn't have to be that bad for the patient to be symptomatic to have things like epiphora. All right. So when we look at conjunctival chalasis, it's important to compare and contrast what you might see in dry eye patients. And I think that this table really highlights this. So when you look at it, the table, it kind of gives you some case history questions that you might want to ask to dive deeper into what your symptoms are really like. So diurnal fluctuations worse in the evening with dry eye syndrome. We know that. These patients tend to have the same complaint all day long. From morning to evening, same level of complaint. The gaze is different. We don't often ask about when is it worse. When you look up, you look down. As we talked about earlier, a lot of people are on screens, a lot of looking down all day long. So our conjunctival chalasis patients may be more symptomatic when they're looking down at a laptop or their phone. Again, with blinking, it is worsened with conjunctival chalasis. A lot of times patients come into our office And we put them behind the phoropter, or you have your technician occlude one eye, and then when they can't read the letters, they go through and say T, Z, V, E, and they pause. What do we all tell them to do? Blink, right? So once they blink, ideally, if it's an evaporative dryness, you're going to see an improvement in the acuity. You're going to see them finish the line. Our conjunctival chalasis patients kind of continue to struggle. It may or may not clear for them. So a punctal occlusion will improve a dry eye syndrome patient versus worsening a conjunctival chalasis patient, which is what we've seen. So what are our options? Our options first are from a diagnostic perspective and record keeping to grade it, okay? Don't just say positive or negative, they have it, they don't, but to actually diagnose and grade it based on the presentation. So if there's no persistent fold, you see it fold occasionally when they're blinking, that's gonna be a stage 1. You go into a single small fold, stage 2, and then when we get into multiple folds and it's really impacting the tear meniscus, that's gonna be a grade 4. So what are our management options? We have surgeons that we work with that do the pinch paste conjunctivaloplasty, so injecting glue in and then resecting that amount of redundant conjunctival tissue. You know, different surgeons may do different things. It doesn't mean one is better or worse, you know, certain proficiencies and what they prefer. So ultimately what we found is, you know, preoperatively you can see the redundancy, and then postoperatively with the remedy of that. There can still be some dry eye symptoms that are going to persist afterwards that maybe need to be managed in all of these cases. It's not to say getting rid of the masquerade element is going to do everything that you need, but definitely addressing all things broadly is the best way to be. I think as we talked about, or maybe Dr. Donenfeld said in the beginning, one of the things that we do a great disservice for our patients is we have a drug that comes to market, maybe a treatment that comes to market. We try the drug, we try the treatment, it doesn't work. We lose faith in it, the patient loses faith in it. And really what it came down to, we weren't going to have that solve all their problems when it's the multifactorial condition, or perhaps one of these masquerade conditions. Any questions? No one ever has questions before lunch. It's okay. I'm really? No, I'm kidding. No, go ahead. Afterwards, that's a good question. So in follow-up with that one, she wound up, I think her best corrected was 20/60 in that eye with the SPK. So it was an enormous, enormous improvement. And once she started taking the amniotic tear, which I have no disclosure to offer for Regenerize either, she wouldn't let it go. I mean, she was very committed to it. And while we talked about pricing and things, and Dr. Yu said, well, you know, it can be affordable, but it's still something of significance in terms of cost. I have had several patients who do not mind using that, and they do offer sort of a discount in terms of getting 3 months supplies and things like that. From my perspective as a doctor, I really appreciate their communication. You know, sometimes you prescribe something and you wonder if it gets into the patient's hands. They shoot me an email that says, your patient, Dr. such and such, has, you know, received their Regenerize and we wanted you to know. Which also for me, it helps me if I want to roll back through my email and find out who's on it. It gives me kind of a retrospective view as well. So for being a pretty small group, they're good on communication. Anything else? Good. Then lunchtime it is.